Thank you very much, Mr. Chairman. Ladies and gentlemen, I'd like to thank the organizing committee with a special thanks to Dr. Ahmed Saadi for the opportunity to share this presentation with you. Well, I will try to share with you lifetime experience in the management of complex ventral hernia. Such a situation, it needs a special preparation and a special concern and a proper preparation as a summary. I would like to start by sharing with you the statement of Sir Cecil Wakely, the president of the Royal College of Surgeons. He said that a surgeon can do more for the community by operating on a patient with a hernia, saying that his recurrence rate is low, than he can by operating on cases with malignant disease. I am going to share with you these topics as objectives of the presentation, starting from important definitions down to the conclusion after the use of abdominal binder, after abdominal surgery, and hernia repair. Number one, we start with the complex abdomen. The complex abdomen may be the one you face in an emergency situation like abdominal compartment syndrome, suture dehiscence, or early laparotomy, as in second look operation in patient with mesenteric vascular occlusion, or in an elective situation in patient with loss of domain, in patient with multiple recurrent abdominal wall defects, closure of an open abdomen in patient with compromised physiology, or the presence of a previous mesh infection, and so all under the need for the removal of the intraperitoneal mesh and adhesions. These are examples of the cases presents to us with a complex abdomen, like this patient with local advanced colonic carcinoma infiltrating the abdominal wall, which result in a complete total hemi-abdominal, full thickness abdominal wall loss that need some sort of management. In addition, the complex wound that you would see in the abdomen is the one which is lasting for more than 3 months, infected with compromised tissue viability and also associated with pathological compromise like malignancy, immune suppression, or patient on corticosteroids. While the complex abdominal wall defect, it has no universally accepted definition, but those 9 items, starting from a larger size of abdominal wall defect, more than 40 cubic centimeter, down to the loss of domain of 20%, are the different condition which you can call this as a complex abdominal wall defect, which requires a special management. And the loss of domain in patient with ventral hernia, just to remind you of the basic teaching of the definition of a ventral hernia, which is the hernia that develops anywhere in the abdominal wall area and overlaps with the umbilical and epigastric hernia, and those are the 6 known types of ventral hernia. If the hernia is not treated early and properly, it ends up in recurrence, and it would progress to a complex ventral hernia. And the definition of the complex ventral hernia depends on 4 items. Number one, the size of the location. The defect is more than 10 centimeter in width. The presence of parastomal hernia, hernia related to the bony landmarks, lumbar and lumbar 1, as well as loss of domain in more than 20% volume ratio. Secondly is the contamination and the soft tissue conditions in which there is a surgical wound, class 3 or 4, the presence of an infected mesh, the innervated abdominal muscles, presence of skin grafting in patient who was subjected to burst abdomen and managed conservatively, then ended up with a large raw area. We all know this scenario. Then you transfer the patient to the plastic surgeon to put a graft, and so on, and the patient with an anterior cutaneous fistula. Or based on the patient history and the risk factor, like patient with recurrent hernia from earlier repairs, the presence of comorbidities, increased intra-abdominal pressure, previous wound dehiscence, and the previous mesh infection. And the last item of the definition of a complex ventral hernia is the clinical scenario, like an emergency situation with bowel resection, intraperitoneal mesh removal, multiple hernial defects, and no primary closure of the abdominal defect is feasible without component separation. I will show you some of the cases that I have been seeing over the last 30 years of different type and the different locations of complex ventral hernia. If you can see this patient here on the right side, this patient has a 8 months pregnant uterus within the hernial sac. She delivers by a cesarean section, and then we prepared her for surgery, and we successfully repaired the hernia. This is a patient in which a general surgeon, as a part of his interesting malpractice, performed a cesarean section for delivering a baby, and in the meantime he did a dermal lipectomy, ended up with a sloughing and with this extensive disfigurement. These are the different forms of complex ventral hernia that we see, which represent a challenge to the surgeon, and you need to have a plan in order to deal with them. Actually, most of those hernia, they have a loss of domain. There is no standard definition for loss of domain. But after all these years, I was able to come with a definition of my own, that the loss of domain, it is a condition in which the reduction of the hernia content without a prior preparation will end up into abdominal hypertension, abdominal compartment syndrome, and or respiratory distress. And the presence of loss of domain and the bowel being outside the abdomen resulted into decrease in the intra-abdominal pressure, dragging on the bowel result into edema and bowel dysfunction. It affected the spine, resulting into a back pain, and also the voluntary straining will result into a progressive lateral retraction of the abdominal wall muscle due to the lack of the coupling mechanism between the right and left hemi-abdomen. It ended up into paradoxical respiration and, of course, the appearance of the abdomen. Well, you see here that the loss of domain, there are certain situations in which you don't operate. The reasons, if the surgeon does not have the experience to operate, or the patient cannot tolerate the procedure, like supermorbid obesity, severe lung disease, smoking, and as a grade 4 and 5, as well as if the repair will not benefit the patient and improve his quality of life. Stable abdominal wall in a dead patient is not a success. For you to objectively determine the loss of domain is by CT scan, in which you measure the abdominal compartment volume, hernial sac volume, and you calculate the volume ratio, and you calculate the volume by the non-mathematical equation of assessment of a volume of an ovoid structure by multiplying 0.52 by the length, width, and depth. If the loss of domain is more than 20%, this patient will require a procedure to improve the abdominal wall and the abdominal cavity compliance. And this procedure will be either by progressive preoperative pneumoperitoneum, subcutaneous tissue expansion, chemical component separation by Botox, or operatively by a component separation procedure, which actually, from my point of view, has a very limited indication in such cases with a moribund complex ventral hernia. The progressive preoperative pneumoperitoneum was first described by Johnny Moreno from Argentina in the 1947. And the most important here, the question that are raised, what are the indications for the pneumoperitoneum? A defect more than 15 centimeter, infra-umbilical defect more than 9 centimeter, or the presence of loss of domain more than 20% of the bowel are habitated within the hernial sac. The type of gas and how much is the volume and for how long, there is no definite consensus about to answer this question, but we use the ambient air because the nitrous oxide, the oxygen, and the carbon dioxide, they are absorbed 4 times faster than the ambient air. So in addition, it's a cheaper, it's a room air. So you will minimize the cost of the insufflation, which lasts for 3 weeks. My practice, I injected 2 liters at first as the insertion of the peritoneal catheter, then 1 liter daily if the patient is hospitalized, or 1 liter every other day, depending if the patient is presenting to the outpatient clinic, or until the patient develops abdominal pain, scapular pain, or he develops dyspnea. After 2 weeks, we repeat the CT scan to make sure that there is a success of the pneumoperitoneum, and we operate after 3 weeks from the start. Keep in mind that if your patient, as you see here in the picture, how the pneumoperitoneum resulted into complete or near complete reduction of the hernia with extra room in the abdominal cavity. So when you repair this hernia, you will have no respiratory distress, and the anesthetist can wean your patient from the ventilator safely. But keep in mind, if the patient was not able to tolerate the pneumoperitoneum, this is a contraindication for surgical intervention, because if you do the repair, he will develop abdominal compartment syndrome. And the chemical component separation was botulinum toxin type A, which is the Botox. We injected at the lateral side of the abdomen, at the mid axillary line, and between the umbilicus and the mid-clavicular line. We inject 50 units at each site on both sides, and then we operate after 2 to 4 weeks from the procedure. Systematic review of the use of Botox, which started 11 or 12 years ago, out of 14 articles, in total 377 patients, they confirmed that the suitable dose is up to 300 units of botulinum toxin to produce an effect within 2 to 4 weeks, and it results in elongation of the abdominal wall muscle by 4 centimeters in each side. Is it attended with no complication so far during the procedure, and it is attended with a lower recurrence rate when it is done either alone or in conjunction with progressive preoperative pneumoperitoneum. Then we go to the management strategies, which is the more topic after this lengthy introductory part. Number one, this complex ventral hernia, the best treatment is to prevent it. Primary prevention of this ventral hernia is important by teaching the younger colleagues how to close the abdominal wall. And Lord Berkeley Moynihan, he was the president of the Royal College of Surgeons and the founder of the British Journal of Surgery. In 1913, he stated that never judge a surgeon before you have seen him closing an abdominal incision. And miraculously enough, over the last decade, it was found that the main discovery for the ventral hernia prevention, it is the small bite closure technique, which halved the incidence of postoperative incisional hernia over 1 year of follow-up. So simply, the recommendation and the current guideline for the closure is that you use a small needle, 26, half circle. You use slowly absorbable or non-absorbable suture material, no more than 2-0. The length of the suture will be 4 times the length of the wound, 150 centimeters. This is the long suture material. You use a small bite, 5 millimeters from the edge and 5 millimeters from each, from between different sutures. And not to be strangulating, you need to see the suture material through the fascia as they close the abdomen. And if you use 2 sutures, don't knot them together, tie each one separately. And the European Hernia Society is recommended to avoid the midline incisions and to use a prophylactic mesh reinforcement of the abdominal wall in high-risk patients, which significantly reduce the incidence of incisional hernia. If the patient developed incisional hernia, the second prevention to prevent seeing this complex ventral hernia is to properly treat the incisional hernia by the concept of primary fascial closure at the linea alba with a physiological tension. In addition, you operate after 6 months from the operation, which resulted into the incisional hernia, to give time for the abdominal wall to recover. Above all, it is very important, any incisional hernia should be treated as early as possible as you pass the 6 months after the operation, which resulted in the development of such an incisional hernia. This is attended with lower complication and attended with a lower recurrence rate. Each incisional hernia should be treated by mesh reinforcement, which significantly resulted into the reduction of the recurrence. And depending on the type of repair and the size of the hernia, you allow your patient to resume activity within 3 to 6 weeks. If the patient after that develop this nasty type of complex ventral hernia, you need to study your patient for optimization and identification of the suboptimal characteristics. You need to examine you need to do CT scan, you need to do pulmonary function test, echo heart, and you study the skin flap design to avoid skin flap necrosis. Determine whether you are going to repair your patient in one stage or more than one stage. Develop the technique of repair and the type of mesh to be used. A multidisciplinary approach, as Professor Safat was mentioning in the management of spleen diseases, also in complex ventral hernia, you need to have a weight loss counseling. You need to have endocrinologists for blood sugar control. You need to keep the hemoglobin A1C. Myself, I don't operate if it is more than 7.5. Some they recommend 8, but blood sugar should be properly controlled. Smoking cessation for 4 sessions. If you are in doubt that the patient did not stop smoking, please do not operate, and do serum nicotine level. It's an expensive test. It's more than 900 pounds, but this will save you and will save the life of your patient, because if they develop post-operative pneumonia, they don't recover. So be cautious. Smoking should be stopped for at least 4 weeks before the intervention. And because those patients have multiple recurrences, multiple hospital admission, you need to screen them for the MRSA. And those are the serious risk factors associated with patients with complex ventral hernia. Keep in mind that the pre-operative preparation is very important in the management of these cases. And if you see a patient like this one, and you can safely repair it with no post-operative morbidity whatsoever, in spite of being a huge hernia with a defect more than 22 centimeter, this is because of the proper pre-operative preparation. A message that you have to get is that never expect that if you don't prepare your patient and improve the abdominal cavity and the abdominal wall compliance before the surgery, that you will be able to do it intraoperatively if you are planning to do a definitive repair. Otherwise, you will stuck with your patient and you will end up treating him as an open abdomen, and you will put a mesh and the evac system, or you will use a silo technique, so you will not do the definitive repair because your patient may develop an abdominal compartment syndrome and he may not be weanable from the ventilator, and the natural disaster, they develop post-surgical pneumonia. The blood supply of the flap is very important. The abdominal wall has 3 known zones. In the middle, zone 1, zone 3 on either side between the costal margin and the inferior border of the umbilicus, and zone 2, it is the lower half of the abdomen. Each one has its own blood supply, and you need to preserve the perforator for the skin flap. In dealing with patients with complex ventral hernia, don't expect that you will have an incision like this one. The incision take different shapes depending upon the shape of the abdomen, the previous scar, the site of the defect, the degree of disfigurement. Even you may end up that by chance you wrote your name as a scar on the abdomen because of the complexity of the skin. If you don't preserve the skin, you will end up with disaster like this one, who needed multiple surgical procedure, and still she has an ugly scar. These are the cases in which they have different multiple defects. Even pre-operative they have an ulcer, but still you can operate on them, preserving the blood supply of the abdominal wall, which function as a syncytium with the right side communicating with the left side, and the abdominal wall has the characteristic of being distendable up to 30 or 32% more in the vertical than the horizontal direction. And the pattern of the fascia, according to our late professor, Professor Omar Askar, which I was honored to chair the unit he was chairing when I was medical student, Professor Omar Askar described the abdominal wall as having a peculiar pattern of fiber intersection, being like a parachute in the upper abdomen and being like a garment in the lower abdomen. That's why when you repair the hernia in the upper 2/3 of the abdomen, you put the mesh in an oblong way, because the mesh is being more distendable and expandable in the vertical direction rather than the horizontal direction. And in the lower third of the abdomen, you put the mesh in a horizontal fashion. And when you choose the mesh, the size of the mesh should be double the size of the defect, plus 2.5 to 3 centimeter. So a defect of 5 centimeter, you need a mesh size of 13 centimeter in order to avoid significant retraction and relapse. The component separation may not be suitable for cases with complex ventral hernia. Why? Because these are indicated in midline defect only. This is number one. Number two, the width of the defect should not be more than 10 centimeter. Otherwise, you will have great difficulty in approximating the midline fascia. In addition, you need to have a good abdominal wall musculature, and you see that those patients with multiple recurrent hernia, they have a weak denervated abdominal wall, and also the component separation index should be less than 0.11. And this is to show you that the anterior component separation give you a length of 3.5 centimeter, while the transverse abdominis release or posterior component separation give you 2.5 centimeter. Study with a huge number, more than 68,000 cases. They compared the component separation versus the traditional repair. They found that the component separation is more expensive and it attended with a higher morbidity. What I described for the management of these cases is what we call the Admire procedure, which is a double mesh intra-peritoneal repair. We started our publication in the Hernia Journal of the Abdominal Wall Surgery in 2005. And in 2018, we have a long-term follow-up after 22 years. In this condition, we use the Vicryl and the polypropylene mesh, and we tailor them together, and we insert them intraperitoneally. And after dissecting the hernial sac and dissecting any adhesion to the inner aspect of the anterior abdominal wall, then we close the hernial sac over it in order to minimize the incidence of a seroma formation and the mesh infection. And you can fix the mesh either by suture or by stapler. And this is a patient after pneumoperitoneum. You see how huge the sac is, but the pneumoperitoneum helps in dissecting adhesions within the hernial sac and helps in reducing its content. And also, if the hernia is complex and huge, and one of the bony boundaries is the symphysis pubis, we described a new procedure in which we create a lower abdominal wall flap using a polypropylene mesh in the retropubic space of radius. It's in the length 15 centimeter by 10 centimeter, and we cover it with the parietal peritoneum and a part of the hernial sac, by which we can fix, as you see here in the arrow showing you the site at which the lower abdominal flap was created, and we proceeded with the Admire, then the abdominal wall is closed. After doing this procedure, the abdominal wall regain its syncytium activity, and you see here the stretch of the lateral abdominal wall after being retracted in the lateral aspect. And this technique, not only this, it can also be used in open abdomen. As Professor Dietz of Germany, he used our technique in dealing with patients with open abdomen to minimize the post-operative incisional hernia with a successful result. He was able to reduce the incidence from 60% to 18%. Like this patient with multiple recurrent intestinal fistula, he had repair done 8 times, 2 times in the state, 2 times in Saudi Arabia, 4 times in Egypt, and he came to us. He was subjected to extended right hemicolectomy, and we use the Admire open technique with a VAC system. The abdominal binder, after systematic review of included 80 studies with more than 500 patients, were not able to confirm or to rule out the value of the abdominal binder, but what is definite is that it is important for the psychology of the patient. After 22 years of follow-up, average of 142 months, we have recurrence rate of 4% in such complex type of ventral hernia. And this is our algorithm in the management. If you have a patient with complex ventral hernia, you do CT scan, you determine the domain by assessment of the abdominal compartment volume, hernia sac volume, and the volume ratio. If there is no loss of domain less than 20%, you can proceed with the Admire. If your patient is a high-risk patient, but the defect is between 10 and 15 centimeter, you proceed with the Admire. If it is more than 15 centimeter, you need to do either Botox or pre-operative progressive pneumoperitoneum. Then, if the patient responds, you do the repair. If there is loss of domain more than 20%, it depends upon if the defect is midline, you inject Botox. If the defect is otherwise, you do progressive pre-operative pneumoperitoneum. After injecting the Botox by 4 weeks, you start the progressive pre-operative pneumoperitoneum. If the patient did not tolerate the pneumoperitoneum, abort the procedure, don't do the repair. If the patient tolerated the pneumoperitoneum, repeat the CT scan and then proceed with your repair. So in conclusion, complex abdominal wall defect not amenable to primary closure remains a challenging problem, and the primary objective of the abdominal wall reconstruction is to protect the abdominal content and to provide a functional support of a dynamic abdominal wall. Surgical management may not be for every patient, for every surgeon, or every institute, and at all time you keep in mind the blood supply of the abdominal wall to avoid flap necrosis. Component separation may not be suitable to such types of hernia. Admire procedure is successful for the repair of the open abdomen. Complex and recurrent ventral hernia applicable to every site of ventral hernia. The mesh is totally hidden within the abdomen with a low incidence of seroma and also a low incidence of recurrence, which is 4% after 142 months. Thank you very much. And
ثانك يو دكتور رأفت. أنا بس عايز حضرتك تعمل announcement. الدكتور رأفت بيه مشكورا يعني مهديكوا بمجموعة من كتبه. would you declare
yes, هو الكتاب ده The Art of Surgical Clinical Examination Evidence Based and the Clinical Atlas. هو موجود النسخ تحت في شكرا.
دي هدية بدون مقابل مالي يعني. لو في one or two comments على ال loss of domain اتفضل.
هو pneumoperitoneum, you have the whole abdomen, you insert the catheter anywhere in the upper abdomen, the lower abdomen, away from the site of the hernia, because there is very important, yes, because very important items you have to keep in mind. In patients with this huge complex hernia, the hernial sac is being festooned and it is turned over upon itself underneath the skin. So you would falsely imagine that it ended here, but in fact it is extended underneath the skin and it may have intestine adherent in it. So you may injure the bowel. So the best thing to do is you go far away from the site of the main bulk of the hernia, in the upper abdomen, in the midline, right or left iliac fossa. It depends upon the type and the location of the hernia. You direct your catheter into the pelvis and you start by injecting 2 liters of air. A most important point, probably I did not mention, but it was written, after the pneumoperitoneum, I apply 2 abdominal binders in order to force the air into the peritoneal cavity so that all the air, by nature, it will go into the hernial sac. Some of them, around 20 to 30%, if you apply the abdominal binder, will go to the hernial sac, and this is beneficial because it will release the adhesions between the bowel and the hernial sac, and these adhesions, streams the adhesion after being separated, the bowel will return back into the abdominal cavity, as you have seen in the picture.
Yes, تفضل يا فندم.
أنا بستعمل 2 types of mesh, وin the current study في عندنا ongoing study بقالها 4 سنين والبروتوكول بتاعها موجود على الclinicaltrial.gov. احنا خلصناها in the process of writing. بستعمل polypropylene wide bore lightweight soft mesh of bard 30 في 30، هي 30 ونص في 30 ونص. ولو هستعمل 2 meshes بستعمل معاها vicryl mesh VM94 or VM95، ده الرقم الكودي بتاعها في شركة اتيكون. الفرق ما بينهم في الحجم، ال VM94 حجمها 24 في 26 ونص، وال VM95 34 ونص في 26، والفرق السعر الدبل.
واحدة بكام يا رأفت؟
ال VM94 ب 6200 دلوقتي، وال VM95 ب 13500. لكن البولي بروبايلين مش يعني ب 1700. يس حضرتك انا برضو علشان الكونتروفيرسي لا معلش. انا I am very happy with this question لو تسمحوا لي اجاوب عليه. احنا في عندنا بليف، وهتلاقي كل الهرنيا سوسايتيز يقول لك it is contraindicated to use the polypropylene intraperitoneally. This is true if you are using the old polypropylene, the heavyweight, thick fibers, because this will form like a plug, and the way of fixation and the way you trim the edge are the one which causes the complication which is reported in the literature, سواء كان fistulation أو perforation أو extrusion from the bowel تطلع من الانس. وعلى فكرة multiple systematic reviews showed that all the literature which contraindicate the use of polypropylene mesh intraperitoneally, they are all collection of case series or case reports, but there is no single prospective randomized study comparing the use of polypropylene mesh intraperitoneally versus other meshes to show whether polypropylene mesh has a higher complication rate.
هو to conclude هم ما بيلزقوش في ايدين الدكتور رأفت، في ايديك ما اضمنش. اتفضل يا فندم، اخر كومنت.
لا قول تاني.
حجمها قد ايه؟ يعني لوس اوف دومين ولا قطوطه صغيره كده؟
لا، ما الصور اللي هو حضرتك شفتها كان فيها اثنين كان عندهم massive ascites. It depends upon the child classification of his liver condition. If the patient is a child C with massive ascites, don't touch him. Wait, if complication happen, you just resect the part of the skin, you close it, and you use glue to minimize the leakage after repeated aspiration of the ascitic fluid with the support of the hepatologist in order to minimize the volume of the ascitic fluid until the wound